from the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist Tony Stewart.
Our topic today is suicides and the problem that obviously evolves from that tragic incident that takes place in families not only in the United States but around the world. And as many of you know, in recent years there has been an increase in suicides, particularly among teenagers or young people. And it's a subject that has received a lot of attention and should receive that attention. It was our goal on this program to assist you in understanding about this subject as it relates to the causes of suicide, what some of the symptoms are that are showing up in individuals who are considering suicide, and how you could be an intervener and try to prevent that from happening. And last, in relation to that, is the preventive process. We have a very highly qualified individual to discuss this very serious topic with us. We welcome to the program Dr. Marie Parkman. Our guest is the Chief Psychologist for Region or District 1 in the state of Idaho for the mental health programs. She holds 3 degrees. First of all, a bachelor's degree in psychology from the University of Oregon. She is the holder of a master's degree from Lewis Clark College in Portland, and that is in the field of education. And our guest is also the recipient of a doctorate in psychology from the Graduate School of Professional Psychology at Pacific University, again in Portland. Dr. Parkman, thank you for coming. We know you have a busy schedule, and our viewers will appreciate, I know, your expertise in this important inquiry into the issue of suicides.
Well, thank you for having me.
And as always, I'm very pleased to have regular panelists, Steve Schenck, who is the Dean of College Relations and Development at North Idaho College, and we shall ask Steve today to commence the questioning.
Dr. Parkman, I wonder if we could begin by asking you to tell us just a little bit about the demographics of suicide or statistics of suicide. I sometimes worry that we try to reduce too many things to numbers, but I'm sure it is helpful to take a look at different groups in society, groups by age or by sex, ethnicity or national background, and see how frequently suicide occurs in those groups. Are there differences there?
Yes, in fact, as you're probably aware, suicide is the solution to unbearable psychological pain, and that can be from many different types of causes. And there do seem to be what we call risk factors or risk indicators to indicate that a person might be at high risk for suicidal behavior. The first is that the person is male. In the normal population, males outnumber females 3 to 1. In successfully completed suicides. In the psychiatric population, that's somewhat lower, of 1.5 to 2 to 1. Whites outnumber all other ethnic groups except in urban areas where it's about equal. The leading group for suicidal risk was males ages 45 to 55 and above. Females tend to peak at age 55 for suicide. However, in recent years, the greatest rise has been in the 35 to 45 age group for males, and that seems to center around economic instability, drug use, and alcoholism, and in the 15 to 24 age group. And whereas suicide accounts for 2% of deaths for the general population, is counting for 15% of deaths in adolescents.
Is suicide and this may seem like an odd question, but is it a highly recognizable crime? I mean, occurrence. We always have a tendency to think of a suicide note and something that's very obvious. And I was thinking about elderly people. I wonder if there is an unreported incidence of suicide among people who are either ill or who are elderly, where it isn't as obvious because other causes of death might be suspected.
Yes, there are other groups that are very high risk for suicide. Individuals who suffer from alcoholism, which is often a problem in the elderly. 25% of alcoholics die by suicide. Individuals who abuse drugs, 10% of them die by suicide. The elderly, people who suffer from chronic illness, particularly renal dialysis patients are extremely high risk for suicide. And so an elderly male with chronic health problems is, for example, very high risk for suicide, particularly if this is accompanied with social isolation, lack of natural supports, and so forth.
You mentioned something that I thought was very interesting, and that was that while whites across the population commit suicide at a higher rate than other ethnic groups, in an urban setting that number equalizes. Do you have some guess as to why that is?
No, the data didn't reveal what the reason for that was. It just is a stated epidemiology statistic.
It made me curious the minute you mentioned that, because for some unknown reason, one of the things that popped into my mind was the notion that it might be the stress of urban living, and I was wondering if there have been, and this is more, I suppose, in the field of anthropology than it is psychology, but if there have been studies done of tribal groups, people living in more what we would call more primitive settings, whether suicide is a phenomenon in those groups or whether it doesn't exist in a less stressful modern environment.
Well, I wasn't prepared to speak specifically to that question. I don't really know, to be perfectly honest. What I deal with predominantly are risk indicators in our culture.
How about other, and I may again be asking you a question that you haven't had an opportunity to research, but are there nationalities? Do the Japanese, for instance, commit suicide less often per thousand population than people in the United States do?
That's been changing in recent years. The highest suicide rate used to be in Sweden, followed by the USSR. Then I believe it was the United States, and I think Japan was actually fairly far down the list.
As we advertise the program dealing with causes, symptoms, and prevention, and certainly Steve has done an excellent job pursuing some of the causes. Let's just take that a little bit further, though, and then I shall move into the symptoms that one finds. You indicate in answering his questions that the economy is a factor and stress is. Would you elaborate a little bit more on that or other causes that cause some societies certainly to be more inclined to have suicides than others?
Well, particularly here in North Idaho, some of the data that have been coming out is repeated job changes, repeated relocations, uprooting and relocating, in young people, in unwanted change of school, inability to stay permanently in one school. I've been associated with a suicidal risk.
Can I interrupt you here just because it's really very, very significant, I think, and that is, it sounds like you're saying, particularly with young people, because they have to move from school to school and they lose their friends and so forth, or people who feel insecure about their job. There seems to be something, and I'm not in psychology, but there seems to be something of disconnecting, not feeling secure and so forth. Is that part of that explanation?
That's correct. For example, in very strong Catholic and Jewish communities, for example, the suicide rate is lower than it is in more homogeneous or heterogeneous urban areas.
That would also explain in part what Steve was suggesting, I think, is that when in past history we had extended families and you might be a whole lifetime in a particular community, you had a lot of support that may be lacking now.
Yes, some individuals, particularly folks who suffer from chronic suicidality, are sometimes characterized as individuals who lack adequate social supports. In other words, they don't have extended family, they don't have very many friends, and they are unable to make use of what is available for one reason or another.
In addition to those factors, what others do you find in the studies causing suicide?
Well, in younger people, suicidality is sometimes associated with family disruption, discipline at school, grade failure, anticipation of harsh punishment, and changing schools. Oh, and also if they have had a friend or relative who has suicided recently, they're at high risk. Additionally, in adults, impending legal action or incarceration is oftentimes associated with increased suicidal risk.
So it's many of these things are disruption in one's life and not feeling how one can cope with what lies ahead.
Clearly, and if you think about unbearable psychological pain, depression is one thing that causes that, but also feelings of humiliation and shame, feelings of failure, feelings of isolation and alienation, chronic illness, loss of ability.
Certainly we see statistics, do we not, that when people have terminal illnesses, oftentimes they want to avoid the pain that lies ahead with cancer and so forth, and that becomes a statistic.
Yes, that is.
Well, certainly you've covered an awful lot of area that explains it, and we're not suggesting on this program that we're covering every single thing, but let's talk about symptoms. That's one thing we want to spend some time on with our viewers. Anything that we can do on this program to help prevent such a tragedy, that would make our program worthwhile. And certainly there are individuals out there we know all the time that are at risk. And so if a family's listening and they have a member of the family that might be, and they may not be very cognizant at this moment, would you help those viewers by suggesting what are some of the behavior patterns for an individual prior to committing suicide? And if I can add to that question, oftentimes after the tragedy takes place, family members say, I just did not see it. If I'd only known if there's something I could do. I want you to take this opportunity to enlighten us about those symptoms.
Well, if there has been some type of sudden change in the individual's life about which they are extremely agitated or preoccupied. Additionally, statistics show that most folks who attempt suicide do tell someone, usually a significant other, within the 24 hours preceding a suicide attempt.
Can I interrupt again? Because you and I talked about this on the phone earlier. There is a misconception out there that the majority of people who commit suicide don't tell anyone about it, but that, you say, is not true according to the studies?
That is not true, because the studies differentiate between suicide attempters and suicide completers. Suicide completers are almost always male, and the first thing they use is guns, and the second thing they use is hanging. With the suicide attempters are usually female, and they usually overdosed or cut their wrists. And with the women, it is more of a cry for help, usually centering around some kind of pain due to relationship issues. So disruptions in a person's relationships, recent humiliation, job loss, economic strife, those are some of the things to look for, as well as depression, change in daily habits, making a will, giving things away, going around saying goodbye to people, maybe even writing letters saying goodbye to people. Because usually people will unless they suffer from a mental illness or other disorganization of their behavior, they will make some plans. Also, too, people should be alert for alcohol or drug abuse, because that's involved in 25% of all suicides.
And if someone is contemplating suicide, are they more likely to increase the abuse of those prior to the suicide?
Yes, they are.
A long, long time ago, we had a guest on this program from the University of Washington. In fact, he had written books and was an expert in this area. And he said something that always stayed with me, and I want to give you a chance to see if you agree with his statement. He indicated that in the last 24 hours prior to suicide, that the individual has been before that time struggling with whether they would or not. They agonize over whether this is the step they're going to take. And he indicated that once the decision had been made, it had been resolved, that the person definitely was going to attempt suicide, that they became different in behavior. They became relaxed, they'd resolved those conflicts, and they lost their depression, oftentimes, and were very happy. And that someone who'd been in depression a long time and considered this, if they got in that state, that was the most dangerous time. Would you agree with that?
Yes, I would. When you see someone who's been depressed and really struggling with a lot of problems, who suddenly becomes happy and carefree and almost devil-may-care, and it's because they've made the decision to kill themselves, and they're not going to have to worry about these problems anymore, because the suicide will solve it. Suicide is seen oftentimes as the way to solve the insoluble problem.
This guest also indicated that when that behavior changed, that somehow, for whatever the reasons was, they tended to set the time, but they took like a 24-hour period or something to engage in happy behavior and so forth, that prior to the actual committing?
Yeah, I don't think that there's a time limit on that.
Okay.
With some teenagers, that can last up to a week or so.
Okay.
But any sudden departure from a depressed state to sudden euphoria or happiness should be noted by family members.
And should we add to that would be without them going for counseling? So, I mean, if they've been getting treatment, their behavior may change permanently to the positive. But what, again, he said, I think, was if this sudden behavior comes and it's not even from any kind of counseling and treatment.
Well, that's true, but even if a person has been depressed for a long time and they have a sudden mood change, that that should be inquired into.
Okay.
The other thing family need to do is if they're concerned that someone is suicidal, they need to ask the person if they have a plan. And they need to inquire about what the plan is and how well-formed it is. The more well-formed the plan, the more access the person has to executing the plan, the more likely it is to occur. Also, too, fantasies of dying and going to some type of afterlife are associated with suicide completers.
So I hear you saying that the worst thing you can do is not to discuss the subject with a person. To try to avoid it is dangerous.
Right, because people sometimes think if they talk about suicide that they'll cause the person to become suicidal or more suicidal, and that is not the case because, as the prior guest indicated, there's extreme ambivalence on the part of the suicidal individual about whether they should kill themselves or not, right up until the act itself, even times. And so the inquiring family member can sometimes help them resolve their ambivalence about what they want to do, including seeking treatment and other intervention.
Steve Sheen.
I know we're going to want to get back to that topic of what do you do if you suspect, but you said some other things that I want to follow up on. And this sounds like a fairly simple question, but trust me, it is going somewhere. I think you mentioned earlier that there are people who attempt to commit suicide who are otherwise mentally healthy, but some people it is part of or a symptom of other mental illness. Is that correct?
That's correct.
Then I guess the bottom line there is if mentally healthy people commit suicide, then each of us is at some risk given the right combination of circumstances of attempting suicide. Is that also correct?
Well, I think that the statistics are fairly clear that in the adult population, I think it's an astounding 90% of most people have thought of suicide at some time in their life. And a recent study of adolescents is fairly disturbing that 62% of adolescents have at some time considered suicide or actual suicidal plan.
Well, now here's where we finally get to what I was leading up to, and we seem to be particularly enamored these days of self-help programs, self-improvement programs, either personally or professionally. We exercise, we watch our diet, we listen to motivational tapes. Is there something that individuals can do? Is there some regimen you can put yourself through that increases the likelihood that given the adversity we all face in life, we'll be able to handle it rather than resort to suicide?
Well, suicide, when a person has reached that point, they have had a constriction or narrowing of their thinking. And generally their thinking has become circular. I can't do this because I can't do this because I can't do that. And they feel boxed in and trapped sometimes. And so suicide is seen as the only viable solution. And so when folks find themselves thinking that, they should be alert to the fact that their thinking has become narrowed or constricted to the point that maybe they need to ask somebody else's opinion about what they need to do about their problems.
Let me get back to something else you mentioned too. It surprised me to hear that the concept of I'm going to an afterlife on the one hand, and on the other hand, at least in some religions, and I think you mentioned Catholics and Jews, a strong faith is something of a protection against suicide. Are those conflicting in any way?
Well, in those faiths, I think that there are fairly severe prohibitions against suicide culturally, and it's not considered a viable option for solving problems. It's just in the newest research that's come out of the American Psychological Association book, The Suicidal Patient, they found that fantasies about meeting someone in the afterlife, greeting old friends, seeing it as a new beginning, as a positive step, you know, as an evolution, would sometimes be associated with higher suicidal risk.
On that point, Steve, he often does, he built the bridge for us, but I have a copy of the book here that you just referred to, The Suicidal Patient, and I believe the subtopic is Clinical and Legal Standards of Care. If I can hold it a little higher. This is not available, I believe, just in the bookstores, but it's, could you tell us a little more about the book and how people could reference it?
They're free to contact me about it. It's written by Bruce Bonger, PhD, who's a suicide expert, and it's published by the American Psychological Association and was available to me through the continuing education program. And it summarizes all of the different risk indicators that I just spoke to you about and different types of research and recent Suicidology is what they call it, and it was published in 1991.
And it's really up to date on the issues that we're dealing with. I have been unfair to my staff because I didn't tell them about any telephone number, and they don't have it for the screen. But I think we will let you give us a telephone number, because any way we can help, we want to do so. And I would indicate to our viewers that Dr. Parkman is headquartered here in Coeur d'Alene, Idaho, and our telephone would be area code 208, and then Dr. Parkman, if you give us your number.
Yeah, the Mental Health Center's number is 769-1406, and that is a 24-hour emergency line for mental health emergencies.
Well, that is really helpful. I'm going to give that again, because I always think that some viewers running to get a pen and coming back to sit down, and so I want to do that one more time. Again, the Mental Health Center where Dr. Parkman is area code 208-769-1406. Thank you. Another issue that came up, and with all the knowledge you have, you just create so many other questions in one's mind. I was very intrigued with the fact that you indicated that of the total number of suicides, certainly in the United States, that the overwhelming statistics are that men are more likely to succeed in doing that, or I thought I read in what you're saying, even to attempt suicide. It reminds me of a conversation that I had yesterday with some people about how women and men culturally deal with stress and problems, that at least a lot of my friends who are women tell me that they're much more likely to discuss their concerns. There's a very wonderful networking, I think, among many women. Men are much more likely to hold their concerns within them in private. Am I getting at one of the roots of this? I really shouldn't be doing that. You're the expert. I should ask you, why are men more likely to commit suicide?
I think that the epidemiology only speaks to the fact that they do. I think it is because men are more unwilling to seek help, and probably that their problems do become more severe before they're aware of them. Financial problems, alcoholism, drug abuse, and divorce and social isolation are associated with men committing suicide. Additionally, men are successful completers. Women are more attempters. So women, 80% of the attempts are women, but 80% of the completers are male.
Oh, I didn't hear that right. That's very significant statistic.
Difference, yes.
Right.
It's because there's also a what's called a risk-rescue ratio that they use to, how great is the risk versus the likelihood of rescue. And men make sure that there's no possibility of rescue.
When you mentioned a minute ago, the methods used, men turn to methods that are more fatal.
Right, exactly. Whereas women leave more of a margin for rescue than men do. And that's not to say that it's manipulative, it's just a difference between men and women in terms of how they go about doing this act.
Although we've woven into some of these other issues this question somewhat, I think we need to get more out front with it. We promised our viewers we'd talk about prevention. What are some recommendations you have for people trying to help individuals that might be suicidal to prevent that from taking place?
I think that they need to take charge in the situation. The ambivalence that the suicidal person experiences makes it very difficult for them to make decisions about what they want to do. And oftentimes they really are looking to someone to make that decision for them. So, for example, instead of saying to the family person, do you want to go to the hospital, say, we're going to go to the hospital now. And oftentimes when I have calls on call, I'll ask the suicidal person, is there someone there with you? And I'm surprised at the number of times there is. And I'll simply get the family member on the phone and say, I think you need to take this person to the emergency room at the hospital to be evaluated for admission. So family become afraid, and they don't want to do the wrong thing, but they need to also take charge. If the patient will not cooperate, then they need to call their local mental health center to find out, or their local prosecutor to find out what involuntary procedures are available in their state.
So I hear you saying while the patient is indecisive, the support person must be very decisive.
That's correct. And oftentimes people are worried about making the situation worse or getting the person in trouble or so on and so forth, and they need to realize that suicidality should be taken very seriously in any person at any time, and they need to take appropriate action.
In addition to that, I have also heard you say today that there are certain things that happen that create crisis in people's lives. So could you elaborate upon how to get rid of some of the crises that may lead one away from suicide?
If a person's in a crisis, they need to make use of the large number of self-help lines that are available. For example, there are now all types of alcoholism hotlines, drug abuse hotlines, sexual abuse hotlines, and they're all in people's phone book. And so when people are, or financial crisis, there's credit counseling available and other types of things. People need to reach out more and take advantage of those resources.
So a lot of individuals who are in a crisis, they don't see that, or they don't understand that what is so serious to them can be worked out, and the day will come they look back on that and say, we were able to work through it.
That's correct. And sometimes they need other people to help them with
Yes.
that. Friends also need to be aware. I think that there's a tendency on people to respect other people's privacy. And if you have concerns about a friend, you need to talk to them about it and see what you can do to help them, because it's very easily, particularly when people are isolated, to just kind of let things go and then you regret them later.
One other area I just must get into, I think it's really important, where there have been suicides, one of the tragedies that oftentimes family members take lots of blame they shouldn't take. Would you address that question where there is such guilt on behalf of family?
Yes, families do tend to blame themselves and say, oh gee, I wish I had taken this seriously, or I had. They can't go back and change that. What they can be aware of is any kind of dramatic change in a person's usual behavior should be inquired into.
One of the questions in that area is that oftentimes people commit suicide, though they do it for some reasons that's not tied to their family.
That's
anyway.
correct.
And it's other matters outside of that.
Yeah, and the family can't accept total responsibility because the suicidal person oftentimes is not mentally ill. They do know what they're doing, and they choose to commit suicide because they see it as a solution to a problem. Now, most of us would not agree that that's an appropriate solution, but that's how the suicidal person saw it at the time.
I have the signal we have 1 minute left, so I'll finish up with this. In dealing with suicides, are you hopeful that we are on top of it and that we might be turning the corner to decrease suicides?
Well, considering that the National Institute of Mental Health indicates that 25% of the adult population at any given time suffers from depression serious enough to require medication, and 20% of the adult population also suffers from alcoholism or drug abuse, I would expect suicide rates to increase.
I'm sorry to hear that, and I'm sorry to end on that note, but again, on behalf of Steve Shink and our staff, thank you so much, Dr. Parkman, for being with us. You have been most informative. Ladies and gentlemen, our guest has been Dr. Marie Parkman, discussing the great problem of suicides, and she is the chief psychologist of District 1 in the state of Idaho for the Mental Health Department. I know you found this most informative, and I invite you to be with us again next week at the same time when we will turn to yet another subject. Until then, please have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Instructional Technology on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station.